into this computer. Okay, so we have two presentations today. The first presentation is by Dr. Hadjesfandiari, which is talking about the measurement of lead, mercury, and cadmium in blood donors of Canada. So Dr. Hadjesfandiari earned her PharmD from Tehran University with top honors and worked as a pharmacist in Provincial Health Network and community hospital pharmacies. Then she came to Canada to pursue her PhD in chemistry at UBC in biopolymers and biomaterials, focusing her research on developing anti-fouling and antimicrobial coatings for the platelet storage bag. After completing the postdoc fellowship in the Devine Laboratory in transfusion science, she accepted a research position at CBS. And began teaching in the Department of Pathology. And in 2004, she joined the Faculty of Pharmaceutical Science to focus on teaching. I'll introduce our second speaker now, and then we'll do both presentations in series. We have Dr. Mindy Goldman, who's the Medical Director and Donor and Clinical Service at CBS in Ottawa, Ontario. Dr. Goldman completed her medical degree at the University of Montreal and did subsequent training in internal medicine at McGill and hematology and transfusion medicine at McMaster. She has over 25 years of experience in transfusion medicine in Canada and is currently responsible for donor criteria and policies related to blood donors and immunohematology at CBS. So I will let our first speaker take it away. I'm no longer sharing. Oh, I didn't realize that. Save. And let's see. Great, you can share your screen. Perfect. I will turn off my audio.
Thank you, Dr. Marcon. Thank you, everyone, for having me today. The topic of my talk is heavy metals in blood donors in Canada. I'm currently an assistant professor of teaching at UBC, but at the time of this project, I was a research associate in Dr. Devine's lab at Canadian Blood Services. And it was an honor, and it will be an honor of my life that I was part of her research lab, and we miss her so much. So you will hear a lot about these three heavy metals in my talk: lead or Pb, mercury or Hg, and cadmium, Cd. Why did we care about these three heavy metals? Well, lead is a neurotoxicant, and lead itself and its inorganic compounds are carcinogens. This is a poster taken from a CDC website. You can see that exposure to lead can seriously harm child's health, damage to brain and neural system, slow growth and development, learning and behavior problems, and hearing and speech problems. And previously, there were reports of safe threshold for lead, but nowadays, if you search what is the safe threshold for lead, there is not such a thing. The approach is to keep it as low as possible, or in Canada, we follow the principle of ALARA, as low as reasonably achievable. And CDC reports a reference, like a threshold for intervention. So what are the sources of lead exposure? On the left side here, you see the traditional sources of lead exposure. Unfortunately, most of them have been banned or decreased dramatically. For example, lead mines and smelters, lead pipes that we are not using them anymore, lead-based paint, again, we are not using them anymore, but it's a problem. You might have seen news from Chicago, Michigan, when there are house renovations, it becomes a problem. And then in hobbies, for example, in fishing, they use it in their beading, and old toys, again, it is banned, and in some artworks. Also, we have some untraditional, unconventional sources of lead exposure. This is on the right side, you can see a photo I took from an excellent paper from, actually, it is a local research group, BC Children's Hospital and CDC. It's a small sample size, but they observed that in the South Asian newcomers, they were focusing on young females, their blood lead level was significantly higher than Canadian-born young women. And they could correlate this high concentration with the daily use of makeup, including lipstick, kohl, sindoor, and henna, with habitually sucking on metal jewelry, and also some traditional medicine. For example, this data point, the highest one. Okay. Sorry, I'm missing my cursor here. This one was, I believe it was a person who was taking some traditional South Asian remedy that could contain up to 2% lead by weight. So about blood transfusion, we can imagine if a unit of blood, a unit of red blood cell contains lead, it can be a source of exposure to lead. And probably for adults, it won't be a problem, but there's concern for premature and low birth weight infants, preterm neonates. We know that they are among the highest consumers of blood products. Their brain undergoes significant amount of development outside of them, that natural environment of womb, so they are vulnerable to the neurotoxic effect of lead more than other blood recipients. Also, this group of blood recipients, they are iron deficient that will work synergically with lead poisoning because they are both double cations. The problem is that our body cannot clear lead, so it bioaccumulates as we age, and it is absorbed in our bone and soft tissues, but it keeps a dynamic equilibrium between blood, bone, and soft tissues. What do we have in literature? We have these publications that they have shown that the post-transfusion infant blood lead level correlates significantly with the amount of
Oh, you were back. You were frozen for a bit. We lost you at some point. Oh, and then I see that you're back now. Okay, you just have to unmute.
Okay.
Perfect.
Where should I start, Dr. Merker?
I think that no, the next you'd already gone through the next slide. Yeah, so I think you can move on to the one after that, I believe. Yeah.
One after this.
Yeah, I think you talked a lot about this one. Yeah, this is maybe where we're. Yeah.
Perfect. Yeah, sorry about that. I don't know what happened. Okay. What do we have in literature about lead and blood transfusion? So they have literature has already shown that there is a correlation between post-transfusion infant blood lead level, significantly correlate with the amount of the lead in the packed red blood cell that was transfused, and they followed these infants at the time of discharge. The level of lead was already lowered, which means that it was absorbed in the mineralizing tissues. Has anyone measured lead in blood donors before? Yes, in Hemo-Quebec. This paper is from 2015, but the samples were from 2006, 2007. It's a big sample size, and they found that 15% of their participants had BLL, blood lead level, above 3 microgram per deciliter. Which is what is this 3 microgram per deciliter? That is a number that they have based on the WHO tolerable dose and the amount of blood transfused to neonates. They calculated that this is the safe amount that can be transfused to neonates. And I'm going to come back to this 3 microgram per deciliter again and again, but just say that it is a safe threshold for neonatal transfusion. And then what they did, that they said that using blood donations from donors younger than 33 years old for neonatal transfusion decreases the risk of transfusion of a unit with a level above 3 microgram per deciliter by 78%. So if we use blood from younger donors, we can decrease the risk of a unit that has a high lead, because as we know, lead bioaccumulates. We didn't find any study that have measured mercury or cadmium in blood donors, and also no information about the Canadian Blood Services outside of the Quebec about the level of lead. So we were interested to find this information to do the similar measurement. Our sample size is small, 2,500. We sampled all permanent donation clinics across Canada, 34 samples per each center. Also, we did some oversampling in some 12 of these permanent clinics. And also we sampled 8 mobile clinics, and each of them had a higher sample size. And I'm coming back about like why we did oversampling in these centers. We did a validation to make sure that our EDTA tubes are good for this kind of measurement. And then also we did a method validation that the measurement that we were doing in our lab, we using the ICP-MS, it's a kind of mass spectrometer, was matching the data that Children's Hospital, BC Children's Hospital get in a clinical lab. So back to the targeted sampling. Our sample size, 2,500, is really a small sample size. We cannot like do anything about like, oh, this is the mean of the lead level in our blood donor, because the sample size is small. But what we were curious about was that like, do we really have donors with high level of lead or mercury in Canada that we should be concerned, and we should be like think about it and have some policies around it. So we were looking for really those donors that might have some like a high level of lead. So that's why we did targeted sampling. What were our like targeted centers? Do we have lead producing mines in Canada? Yes, in New Brunswick, Nova Scotia, and BC. Nova Scotia, according to the statistics of mineral production, it had no production since 2008. So the active one is in New Brunswick, in Caribou, southwest of Bathurst, and in BC, it is Myra Falls, 65 kilometers west of Campbell River, and it is in Vancouver Island. We have lead metallurgical plants in Bathurst, Mississauga, and Trail. And then also based on the previous literature, we did some targeted sampling where we have more South Asian donors, Surrey, New Westminster in BC, and Brampton and Mississauga in Ontario. And also we looked at the centers that in media, there were reports of high lead in it. You might have seen, like, I think it was during COVID, if I'm not wrong, that there were a series of publications in Globe and Mail and in Toronto Star that they were reporting that the high level of lead in the water of some schools, that was due to the lead pipes. So we looked at those centers that were reported in media as well for our targeted sampling. Now I am like finally to the results. So this table has a lot. We don't need to look at everything, but what basically we have the GM, the geometric mean of the blood lead level in our samples. We have the range of the concentrations, but I would like to focus on the right side, samples above threshold number. What are these thresholds? The 3.1 is the neonatal, the safe threshold level for neonatal transfusion. We have 55 donors having a higher level than this threshold. It is 2% of our samples. Above 5 is the reference level for investigation by CDC. We had 16 samples above this level. And then we have a 10, threshold. This is the intervention level by Health Canada, and we only had one sample above this level. What were the predictors of blood lead level? One is the first one, sex. So you can see we have a relatively balanced sample size, female and male, and you can compare the geometric mean. The difference was significant. Blood lead levels were significantly higher in male donors. And these are again the number of the samples above thresholds. And again, we can see in male we have like bigger sample above those thresholds. And donor sex explained 4% of variation in blood lead level. The second predictor was age, and its contribution to the variance is bigger than sex. Donor age explained 18% of variation in our sample size. You can look at this graph. It is clear. It is the donor age on X, 17 to 27. They have the lowest level of lead, and it is increasing as we go above 65. And there is in this table, you can see the significant differences. Next one, donation clinic. So sorry, I think it is a bit small, but from top to bottom, we have our provinces from West Coast to East Coast. And I'm going to click and show the centers in red that had higher blood lead level compared to the centers in blue that had lower level of lead. So these are the significant differences, the statistically significant differences that we saw. These samples here on the side of the table are the ones that have significantly higher lead level compared to the samples Alberta, Ontario 8, 14, 21, and Nova Scotia. Right. This is wrong, it should be lead. What was interesting for us to see? One was that there's 3 centers within 80 kilometers from the 2 active lead producing mines of Canada that we have, Campbell River, Comox Valley, and Batters. All of them were among these 8 samples that had significantly higher lead level. So they had the risk factor, and also in our data, they showed up. They had really higher levels. And also the clinic name contributed significantly to blood lead level. After age and sex, the contribution was 1%. Also, I would like to talk a little bit about these centers that you see that they have significantly higher level. I'm showing the data just in another way. This is deviation from the national average, the geometric mean. And you can see I have Ontario 16 on the top. Let me go back and show you. We were working with a statistician, but also in my head was is over targeting biasing my result? Will they, because I am putting more weight on these centers, do I bias my data? But you can see that among these 8 centers that had significantly higher BLL, we have some of them that were not actually targeted, like BC 3 and Ontario 16 and New Brunswick 2. So it was for Ontario 16 specifically, I was very interested because as you see, the difference from the national average was the highest. And we had not even considered this center for over-targeting. So after the data analysis, everything was over, I started looking into Peterborough, and I understood that there is a General Electric plant in Peterborough, and it has been there 126 years, and it was closed just in 2018. And there are not I couldn't find any peer-reviewed literature about the lead level in soil and water of Peterborough, but there were media reports and also some open access papers that I could look, for example, this Lethal Legacy in Toronto Star. It talks about like lots of contaminants in this GE plant. We have this report about this gentleman with advanced glioblastoma that was working with 42 deadly substances, and one of them was actually lead. And this other paper about workers' fight for justice. And this governmental report from Ontario Ministry of Labour that in 1968, this plant took 40,000 pounds of lead a week. So it was interesting. Our sample size is, again, I emphasize, this is a small 35, but like Peterborough showed up, and I think it was a learning moment for me. But back to our purpose, the median age of the study donors in this clinic was 64. So it is possible that some of them were actually in GE. But it is also possible that the water or soil has contamination, but we don't have any information. So I cannot really say anything about this data. Is it about occupation or other factors in play? So here I am stopping lead data and moving to mercury. Mercury also, it is a neurotoxicant. We all know the main source of the exposure is diet, especially the larger fish like tuna fish and swordfish. Also, based on literature, our oversampling or for targeting, we looked at the ethnicity. So we looked at the centers that had higher Asian ratio in the population, Richmond in BC and Markham in Ontario. Do we have any information about the mercury and blood transfusion? Yes. Again, the significant correlation between post-transfusion mercury levels and amount delivered by the red blood cell unit has been shown in literature in low birth weight infants. Good news is that our body can clear mercury, but these papers discuss that low metabolism and excretory abilities of premature infants is a concern associated with their exposure to mercury. So our results, again, you can see the range of the blood mercury level in our donors, the geometric mean, but I focus on the right size, the number of the samples above thresholds. So we have 3 thresholds here. First 8, it is the maximum acceptable level in children, pregnant women, and women of childbearing age by Health Canada. And we had 23 individuals above these levels. And out of these 23 donors with a level above 8, 5 of them were women of childbearing age. We have this 9.5. This is the safe neonatal threshold. Again, it is done by a calculation based on EPA reference level and volume of blood transfused to neonates. 11 of our donors had a higher level than the safe neonatal threshold. And then we have 20 microgram per deciliter, which is the maximum acceptable level in blood for adults by Health Canada. So for the general population, other than the pregnant women and young women, we had only 1 donor above this level. What are the predictors? Sex is not a predictor. You can see the geometric mean didn't show any significant differences. Also the samples above thresholds. Age, it is a predictor, but it's not as significant as the impact of age on the lead level. The correlation is very weak. And also, as you can see in this image, and also in the table, it seems that the correlation is driven by the youngest group of donor. And it might be just due to the choice of their diet, that they had the lowest small. And it was interesting for me that, it seems I'm very clumsy with this clicking. The youngest group of donor, it was interesting to see that the CHMS data also reports that a similar, they have a similar trend that the youngest group have the lowest. And in other groups, among the other groups, we couldn't see any really significant differences. donor age explain 2% of the variation in blood mercury level. Now, like donation clinic, again, the same thing. We have the names of the provinces and the clinics in them. We saw more variation compared to the lead. And then I'm doing the same thing. I have the centers with the highest, significantly higher level of mercury red with the significantly lower level of mercury in blue. And what was notable to us is that like 5 out of 6 prairie clinics had significantly lower mercury level than at least one clinic in British Columbia. Also, 7 out of our top 10 mercury samples, so when we listed all of our samples from highest level of mercury to the lowest, 7 out of top 10 were from Metro Vancouver and Toronto. The other 3 were from Victoria, Campbell River, and Kingston. And for mercury, the clinic name was a stronger contributor to the level of the blood mercury. It explained 10% of the variation. And let me see how we are with time. I will quickly say something about because I didn't put it here, but I would like to mention, if you remember, for our targeting the samples for mercury, for oversampling, we've looked at the Asian population. We oversampled Richmond and Markham. And the Richmond is BC7. So actually, it was the center with the highest geometric mean. Yeah, so it was interesting. Okay, and also I must say, over all our donors, the ratio of the Asian donors was 5%, but in BC7 we have 37% of our donors were Asian, and they had the highest geometric mean of mercury level. But and also Markham is Ontario 14, the center. So again, it appeared in the highest one. But also I would like to point out that Newfoundland, that actually had the second highest mean of the mercury level, they didn't have any Asian donor. It was just 0 donation from Asian population. So after the study was finished, we concluded that maybe we shouldn't have over targeted based on the ethnicity. We should have targeted the coastal clinics. Now I'm moving on to cadmium. It will be much a shorter. Exposure to cadmium is also associated with adverse neurodevelopmental effects in children. It's a group 1 carcinogen, nephrotoxic, increasing risk of insulin resistance and risk of heart failure. It can be eliminated from our body, but the excretion rate is low. And the common source of cadmium exposure is smoking. For the non-smoker, it is the green leaf plants, because cadmium has a very good solubility and mobility compared to other heavy metals. So it is uptaken by plants, and that can be the source. And also it is for art, those who people artwork, and they use maybe paint with their hands, and cadmium has a very beautiful yellow color that can be in these paints. And we didn't do any targeted sampling for cadmium. We just measured it along others lead and mercury. And as you can see, with lead, we were talking about microgram per deciliter. With mercury, we were talking about microgram per liter, but we were in higher range, 20. Cadmium level is pretty low. So more than 20% of our samples during the measurement were actually below the level of detection. So that's why we cannot report really the mean of the samples, etc. And we mostly worked on the median and 90th percentile. The median of blood cadmium level was significantly higher in females, and it makes sense with what is reported about the way it is metabolized. And age, median and the percentiles had an increasing trend with age, so we have a bit of accumulation. And then clinic, we had some centers, as you can see clearly in this graph, that had highest level of blood cadmium, but we don't really have any knowledge about like, are these donors smokers or not? Do we have a higher percentage of smoker donors in these centers? That's why. So I'm not going to like make any conclusion out of it. So for the summary, blood lead levels are significantly higher in male and older blood donors. We have 3 cities in close proximity to 2 lead-producing mines, and they were among those 8 clinics that highest blood lead level. Also, it was interesting to see that 7 of the top 20 donations with the highest level of blood lead level were from these exactly these 3 cities. And then blood mercury levels are significantly lower in young donors and higher in coastal clinics. And in our donor population, with this sample size, we observed blood lead and mercury levels that were higher than the safe thresholds for neonatal transfusion. Our data support the discussion of the relevance of considering blood transfusion as an exposure source to heavy metals. And then what was next for us, and maybe first I must say that it is like a science group point of view, because we are not clinicians, we are like researchers. We collected this data, and what we thought after it, we thought that like maybe we should reconsider having clinics in Bathurst, Campbell River, and Comox Valley, because they have higher blood lead levels. They have known lead exposure factor, and actually they have a small number of donations. So these are I have just put the numbers here, and in 2021, I think the total number of donation was 750,000. Or we can divert these units to preparing only plasma and platelet, because lead, 99% of the lead is stored in our red blood cell. So these units can be like very well used for the only plasma and platelets. And then we can have informed selection of blood units for transfusion to neonates or vulnerable groups. For example, if we use donor age or clinical location for selecting the units for neonates in the transfusion. And then we can have like we can have donor questionnaire to identify donors at varying risk of having high heavy metal levels, for example, in case of diet or occupation. Or we can like communicate with donors some of the things that we know. For example, when they do the online booking, we have a message that limit if you want, limit the intake of large fish in the month prior to donation. And maybe some donors are willing to do this when they book their blood donation time. And then I must say that our focus was direct risk to vulnerable neonate population. But as you know, we have lots of like these REDS3 metabolomic data coming from this US studies that they show the impact of small molecules and drugs on the RBC storage quality. So this can be something that like, one is the risk of the heavy metal itself, and the other one is also how it impacts the quality of the red blood cell. And this is something that we did not really go into it. And then in the end, I think this is like probably the most important from your point of view is the clinical data, that all these numbers that I said, oh, this is neonatal safe threshold, 3.1 or 9 for the mercury, and these are higher than these levels. We don't have any clinical data on these, and there is no like clinical like evidence that has evaluated the impact of amount of lead or mercury transfused in the neonatal period on the neural development achievement later in the life. So that, okay. And Dr. Michael Murphy lab is the lab that they gave us their ICP-MS to use for this project. Dr. Burkauskas from BC Children's Hospital was involved in the when we were doing the method development, method validation against their measurements. At that time, Dr. Chilang Yi was also in Canadian Blood Services. He helped out with statistics analysis. testing centers in Canadian Blood Services sent us these backup tube that they had for testing for our measurements. We didn't ask for extra blood from donors. And then for this study, we got funding from Canadian Blood Services Blood Efficiency Accelerator Award Program. And thank you so much for your attention and having me again. Thank you.
Thank you so much. I have lots of questions, but I was going to say maybe we'll go to Dr. Goldman's presentation and then we'll do questions for both of you at the end, just so that if people want to stay for extra questions, we can. Does that work? Okay, perfect.
Are people seeing my screen?
Yes, it's coming up. Thank you.
Okay, great. Well, thank you very much for inviting me to present at these rounds. I'm going to broaden out the topic a little bit and talk about unexpected findings in donors and trace substances in donations and what to do. So starting off with unexpected finding in donors or in either their tests or in their components. So as you probably know, we have policies on informing donors of expected abnormal or unusual findings. And these are standardized and detailed in work instructions. So these are things like donors that are repeat reactive on transfusion transmissible diseases or have a repeat positive direct antiglobulin test or have a rare blood group. However, there are other unexpected findings, and these are evaluated according to their potential significance to the donor, their impact on product quality, and recipient safety. So if we look at a few examples of these more unexpected findings, how do they come about? So we have a good example of one that we've just heard about. So how about a research study that is performing additional testing? So you might have a predictable unexpected finding there. For example, there's a study happening now at UBC where we're measuring hemoglobin A1C, a marker of high glycemia and diabetes in donors. So you could find, since that's what you're measuring, you might find some that are high. So that is a predictable finding in that study. Or it could be a totally unpredictable, unexpected finding. So for example, you may be doing a study on blood storage. You just happen to find that there's a unit that has a lot of hemolysis, something that we're not routinely measuring on every unit. And then when you do a blood film, you see that that donor actually has spherocytosis. You can also have an unexpected finding that you find on routine inspection and in testing. For example, you can see these test tubes here are very lipemic. That might be a donor with a metabolic disorder and very high triglyceride level. And so that is unexpected. Or the hospital blood bank may have an unexpected finding. So you may have a unit, for example, like you can see here, that has visible clotting and fibrin strands, and find that this unit has E. coli on culture. So the first thing to think about on the donor side for these unexpected findings is, are the findings relevant to donor health? So there is in the CSA standard, so that's the Canadian Standards Association standards for blood and blood components. One of the standards is that a blood center physician shall establish the means of notifying donors of any medically significant abnormality detected during the pre-donation evaluation or as a result of laboratory testing. So if we did have an unexpected finding that we thought was of importance for the donor's health, we would inform them of the finding and we would advise them to see a healthcare provider and have the test repeated. We usually do what we call an external medical inquiry. So we tell them to go see an outside practitioner have the thing confirmed or further testing done. Depending on what the unexpected finding is, the donor may have no deferral. For example, a donor with a high level of hemoglobin A1C is not going to be deferred. Or they may have a temporary deferral until the medical inquiry is resolved. For example, is the E. coli related to an underlying problem with diverticulosis, let's say, in the donor? Or are we not able to establish the origin for that bacteria? Does the donor indeed have spherocytosis or not? And then the donor may be permanently deferred if on getting back that information, we feel that the product quality or recipient safety will be affected on future donations. So, for example, we would defer a donor with known spherocytosis because it's known that the red cells don't store as well in from those donors. So what happened in this case? So I was not a member of the research team, and the research team had not determined a cutoff and course of action for high levels. So what is a high level and what's going to happen if we find a high level? So when I was presented with the results, I'm no expert in toxicology. So what I did was I spoke to 3 toxicology experts. 2 of them were actually in BC and were known, helped the research team help me contact. And the third was my own due diligence, who is the physician who's head of toxicology for the provinces of Ontario and Manitoba. And I asked them what they would do if a patient was sent to them that had testing, had testing and had the levels that we saw in this study. And these are people who are presumably feeling well, because that's the first question that we ask the donors. So they remarked that there was some difficulties in interpreting the data because mercury levels may be affected by seafood consumption in the last 2 weeks, as Nargis mentioned. So we don't know, obviously, what the donor had right before they came in to donate. And they said that 3 donors had levels that would possibly trigger action in an adult patient, 1 for each metal. So I did notify these donors of their results by letters, and I included a number to call, my number, for more information. And also with the letter, we included instructions for their healthcare provider on how to obtain repeat testing, because obviously it's not something that a general practitioner or a physician in a walk-in clinic is going to know how to get cadmium levels tested. We put a deferral code in their donor file. So this is, we were following basically our external medical inquiry route, and that code could be removed if they have repeat testing showing normal results. And none of these 3 donors contacted me, and to my knowledge, none of them came back. So that's what happened to these donors in this case. So now, what if we look at product quality and recipient safety and trace substances? So this issue actually comes up very frequently around donor medication use. So about 1/3 of eligible donors are on some type of medication, and probably that would go to the audience of people on this call. Most of us are popping something. Medications can have pharmacologic effects that might be undesirable for the person taking the medication, or it's in excess of what you're after, or maybe for somebody else if they actually do not have the underlying condition. So a good example is antihypertensives. So antihypertensives are in the top 5 of medications that donors are on, not surprisingly. And if you take too much antihypertensive and you're not hypertensive to begin with, perhaps you could become hypotensive. They can also have toxic effects that might be undesirable. So, for example, some medications have neutropenia as a toxic side effect for people taking the medication. And finally, they can have contraindications in pregnancy due to a variety of reasons. One might be just a lack of data, that the medication has not been tested yet or tested in pregnant people. Or it could be that there is animal data that shows teratogenicity in animals, or it could be that there's actual evidence of teratogenicity in humans. So what to do about all these donors on all these medications? So I think what's very important is to distinguish between exposure to medication by transfusion versus therapeutic use of medications. So when a donor's on a medication and a recipient is going to get a product from that donor, this is going to be a single exposure, while most therapeutic or adverse events require a steady state concentration and exposure over time. The amount of medication in the component is going to depend on the component, usually with a higher amount of plasma from a single donor associated with more exposure. Most of our products now are in an additive solution in terms of red cells and platelets and have a lower amount of plasma. And pooled components and components in additive solutions will contain less medication. Transfusion is going to be followed by immediate dilution in the recipient's bloodstream, and then further dilution will occur if the recipient is bleeding or receiving other blood components, both of which are pretty common in people getting blood. And for teratogenic medications, a certain amount of the medication is going to have to go across the placenta. And SD plasma and plasma protein products, which are made from pools of thousands of donations, will contain very low or undetectable levels of medication. So for these reasons, there's actually very few medications that are reasons for deferral. We defer for potential recipient risk for a specific infectious agent. For example, donors on antibiotics, donors who received growth hormone that may have been in an era where we were using human growth hormone and there was a risk of CJD transmission, donors getting live attenuated vaccines, and donors on prophylactic medication for HIV. We also defer donors where there's possible donor risk and possibly impact on the product quality, such as donors on anticoagulants or antiplatelet agents. We don't make platelets from those donors. And then possible recipient harm. And I have to emphasize that the possible recipient harm is really theoretical because this has never been shown. So medications that show clear teratogenicity in humans will be a cause for deferral. Many of these we ask about directly on the questionnaire. And then immunosuppressive agents, where there is a high percentage of the pharmacologic dose in the bloodstream. So these are often biologics that are given intermittently by injection. And so they are at quite a high level in the bloodstream for quite a long period of time. And all new medications are reviewed by a pharmacist and discussed at our donor selection criteria working group, which is a joint advisory committee between Canadian Blood Services and Héma-Québec, and the pharmacist is part of that group. So what about heavy metals? So if we think about heavy metals, here again, it's a single exposure, while most adverse effects require a steady state concentration and exposure over time. The amount will again depend on the component that the patient is receiving, and pooled components and components in additive solutions will have lower concentration. There will be immediate dilution in the recipient's bloodstream and further dilution if the recipient is bleeding or receiving other blood components. And for fetal effects, the metal must traverse the placenta. And in SD plasma and plasma protein products, there really should be very low or undetectable levels of these heavy metals. So what is our current approach? So there are no specific questions used to identify donors who might have heavy levels of different metals. This applies at Canadian Blood Services, Héma-Québec, and I believe for every other blood supplier. Higher lead levels in general are found in people who live in countries with higher lead exposure. For example, where there's still use of leaded gasoline, and Nargis mentioned this. And higher mercury levels are associated with seafood consumption, and they fluctuate over time. So older donors tend to have higher levels, but that's not necessarily true for an individual donor with a particularly high level. I could also point out that at Canadian Blood Services, over 30% of whole blood units are being donated by donors over age 60, and over 6% of whole blood donations are now being donated by donors over age 70. So older donors at the moment are a very significant percentage of our overall donor population. Now, if a donor specifically mentions that they have high levels of lead or they're being followed for high levels of another metal, so this might happen for workers, for example, in a smelter, then they would be temporarily deferred until information is obtained about the actual current level, and then we would assess if we thought that specific donor should be deferred. So that is the end of my presentation, and I'll be very happy to take questions.
Thank you so much. I have questions for both of you, and I know we don't have tons of time, so I'm going to open it up to the audience to start asking their questions. I see Sakara is on the camera, so she must have something.
So first, thank you, Dr. Goldman and Nargis for the talk. Very interesting, and congrats for the publication. Maybe I'll ask Nargis first. Because the test for the heavy metal level was performed on plasma base, right? So how much do we know about the intracellular, particularly red cell? Because if we concern for the neonates, most of them, particularly premature, they receive red cell more often than plasma or platelets, which is contained some plasma, but much less this day because of platelet additive solution. So cation, depends on how it gets like oxidized. You have ferrous that bind with the heme and form hemoglobin. Did it bind with the globins too? And then is there any study show that intracellular like red cell component had as high level of metal like heavy metal compared to the plasma component? Thank you.
No worries. Excellent point. You got it totally right. So 99% of the lead in blood is actually stored in red blood cells, exactly because of the reason you said, because it is just you look at the periodic table, these double cations and with on a relatively similar size. Wherever iron wants to do something or calcium wants to do something, lead is competing. So it can sit and bind to heme, and that's why that 99% is actually stored in our red blood cells. We don't have much problem with plasma and platelets, even if the unit is from a person who has high level of blood level.
I'll give it over to Dr. Seftel to ask a question. His hand's up.
Thanks very much. Hopefully you can hear me. Great talks for both speakers. This is a question primarily for Nargis. So my understanding about lead exposure is that this can be a cumulative, lifelong series of exposures, even dating back to several decades. And if you account for the fact that Dr. Goldman mentioned that so many blood donors are older, over 60, over 70, etc., how do we know that those measured lead levels were not from exposures that are long past? So, for example, childhood and adolescent exposures, even from other jurisdictions outside of Canada. And you particularly mentioned that there's so much lead exposure in developing parts of the world. So I'm struggling to understand whether we're just measuring sort of distant lifetime exposure versus recent exposure, for example, with, from foodstuffs like marine insects, that kind of thing.
Right. So, I'm hoping that I got your question right, but like I don't agree with this sentence that we say single exposure to lead is not a problem. I don't agree with this sentence because we cannot get rid of lead. That's the end of it. So lead comes to our blood. It is absorbed by the mineralizing tissue the fastest, and then we have a dynamic equilibrium. So if you have a recent exposure, or if you had an exposure to, for example, I'm from Iran, and until I moved out of Iran, there was lead gasoline there. Yeah, so I have been exposed to it. I was studying in Tehran, very polluted city. So when you take my blood sample, you cannot say, is this the level that you see is recent exposure or the exposure that I had 15 years ago. So because it comes in, it is absorbed by our soft tissue and bones, but it has a dynamic equilibrium. So that's why we call it bioaccumulation. And I think one of the point that we say the lead exposure happens in in other countries. It is true that Canada has one of the lowest heavy metals levels around the world, but I think our population is changing. We have lots of immigrants, and this study by BC Children's Hospital recently, it just shows us that immigrants like me, we are coming from developing countries, so much going on, and we have been exposed. So I think we maybe a bit of awareness around it, that we have a population of, we might have a population of donors that they were actually exposed to the leaded gasoline. Yeah, did I answer your question?
You did answer it, but I think it emphasizes that understanding exposures and epidemiology is tricky when the blood donor population is so varied in terms of their migration patterns and history.
Mm-hmm.
But yeah, no, thank you. You did answer it.
Thank you.
I have one for Dr. Goldman from the chat, direct chat to me. So question is, what in these scenarios, like for instance, that you mentioned that the patients you called that were deferred, what does that mean here? So what happens to that blood that's already in the system?
Yeah, so
yeah.
the blood has been transfused. I mean, these were not done in real time. The blood has been transfused or discarded, a bit outdated. And I don't necessarily think that it would have been problematic if we still had it in inventory, although we may have done a precautionary, recall. But the blood has been transfused. There's no known adverse effect for, as I said, what is a one-time exposure. And so I really think the issue here was more, was there anything of importance for that donor's health, and then to defer the donor from donating further until we could resolve, do they have a chronically high lead level, or do they have a health issue? Is there anything there that we should be concerned about? That's a bit different, though, than saying we should test all the donors or try and figure out how we could, not use older donors for certain things. To follow up on Dr. Seftel's comment, our donor diversity is greatest in our first-time younger donors, as you would expect. Canada is a much more diverse country now than it was when our 70-year-olds started donating. So, you know, there's that end of things as well.
Thanks. And one last question I got. The question is, are neonates given blood from donors that are younger to reduce heavy metal exposure? I think the answer is no to that. That we don't have any sort of younger donor policies.
No, we don't.
No.
There's other attributes that physicians are looking at for neonates, which probably other people on the call would be better able to say what their policies are, sometimes fresher units, etc. But we don't have a policy at this time in Canada on the Canadian Blood Services side.
Thank you. And maybe we'll do one last question from Kaylee, who raised her hand. Kaylee, do you have a question? We cannot hear you. If you take yourself off mute. Or if you want to pop it in the chat, then we. Okay, otherwise, if there's no other questions, then I just want to thank both of our speakers. That was very informative. Thank you both for presenting to our group here and kicking off our 2025 BC Transfusion Medicine Rounds. I don't know if I say this a lot, but if you do have any suggestions for speakers for Transfusion Medicine Rounds, please feel free to email me because we're always looking for speakers. And if you're ever interested in helping organize, also please feel free to email me. And have a great rest of your day. Thanks, everybody.
Thank you.
Bye.